I thought maybe I might ask a question maybe of Derek, if that's okay to start with, because Derek didn't speak, but obviously it's quite a nice series of talks there, but particularly patient being the centre of everything, and we haven't heard about the patient's perspective. So I'd be interested in what the Irish patient and public view of digital health would be, and what do they recommend with regard to digital healthcare. In particular, I suppose there's been a citizen's jury about AI and healthcare in the background. So any thoughts you have in that area, and also of the presentation so far?
Thanks, Tim, and thank you for the invite.
I should say Derek's iPose. You might, if you don't mind mentioning that, I should have mentioned that.
Sure. So I guess I'm on the stage because I represent an organisation that is the largest network of patient groups and individual advocates in the country. We have over 150 patient groups, about a third of whom are actually funding research. And we work closely with our colleagues in the Health Research Charities Ireland group on that front. But I think the purpose of my being on the panel today is around digital and digital health, and the work we've been doing over the last number of years around electronic health records, around how you embed research into a health system, and also around what the health-interested public, who we also have the reach and the power to reach, what they think about the changes that are coming down the tracks that we've heard all this morning. So what I've definitely heard this morning is a very clear articulation of the road of travel that we have to travel over the next 5 years, both from a legislative but also from an investment perspective. What we've learned by asking patients and the public what they think is, yes, they want to be part of this. They're ready for what you might call the digitalization of healthcare records. But the fact is they want to know what good looks like. So only through articulation very clearly of what it looks like and feels like to have not just access to your health record, but to start using it for different purposes. That's what they want. And it's very clear that the European and Irish legislation is designed to deliver what patients and the public actually want. The question is, how engaged have they been to date, and how can we embed that in the way that we develop digital health in the country? Because, as Dermot has said, certainly the paternalistic way in which we look at patient engagement is all too real. And for those of us who have been trying to move the needle on this, it requires support, it requires thought, and it requires time. And when we look at the timeframes in which we are going to have in terms of 4 to 5 years, and we look at the digital roadmap, that the kind of building blocks for meaningful, sustainable, inclusive engagement are actually loaded at the end of the process rather than at the beginning. So certainly what we've learned is you need to start early with the digital health literacy programs. You need to start with embedding roles and responsibilities for patients and the public in the development of the solutions. And what that will ultimately realize is that there's 3 things associated with sustainable, meaningful, inclusive engagement. And one of the best surveys, or the results of the survey that I've seen in this area, in the whole area of digital health, has been the TDIS survey, which is all about it's a project that's designed to deliver on the European health data space. And they surveyed over 6,000 people in the UK, Belgium, France, and a number of countries. And they came up with 3 themes that they learned from what citizens and patients want from this. And one is they fundamentally see this as a relationship. And it's a data-driven relationship between patients and service users and their healthcare professionals. And that's what the digital agenda is designed to improve. The second thing is the power imbalance, because you tell me if, say, a patient with Duchenne's muscular dystrophy, what they value, whether they can value texting their friends over elongation of lifespan. These are the kinds of tricky topics that patients actually have to deal with in everyday lives, but it may be even trickier for healthcare professionals to actually shift the power towards what patients want versus what they have been trained to deliver. Another good example would be Alzheimer's patients. Do Alzheimer's patients actually value living at home more than maybe, a small increase in cognitive ability? So these are the kind of tricky challenges that we've been working with in iPOSI, and certainly through the advent of digital health. These will start to be unpicked and uncovered as that kind of power shift. And the third aspect is a citizens-driven framework. So that's where we, as a nation, and our health service we need to change the narrative of that it's very much around what we want to see in our health service, but how we want to be part of that. So that citizen-centered approach is definitely something that it's so clear that it has to happen, but it has to happen now, so we can avoid the situation where we go down a particular route and we realize, I was fascinated by the Dutch example, where you feel you're going down a particular route because maybe you're compliant with GDPR, but when it actually turns out that it's not practical, you have to then pivot. So expectations will shift along that time frame, but we need to embed the engagement and the spaces to create engagement during that period.
Yeah, the GDPR issue, obviously, sometimes we find in Ireland that can be concerned, in effect, actually, not only patient care, because it's so rigid in certain fashion or interpreted rigidly, but also research has become quite difficult here. And the problem that I've often had the sense is that the patient suffers. They don't have the potential option to partake in research, and there's great potential benefit for that, but they get more attention, but also they're contributing to further knowledge, etc., new treatments, which is a problem. So the opt-out and opt-in model that certainly Margaret talked about is interesting. What's your thoughts, Derek, about that opt-out, out-in model? Which would you think the preference would be from my iPOSI perspective?
Well, first and foremost, most of the patients and public that we engage with, they cannot understand why there isn't a single data protection impact assessment for any secondary use of data in Ireland, and why there is this mishmash and misinterpretation in different settings. So, and also the ethical aspect, the ethical the research ethics structure that's there is not helping research to flourish in the system. So they can't understand when researchers come to them saying, I had to go to all of these different settings to get all of these different permissions, and it resulted in delays. So we're now actually starting to get evidence, albeit anecdotal, of the impact of those delays for research in Ireland, and it's really concerning. So how can we improve it? It's kind of coming back to the whole issue of making data available in a transparent way and building that trust to ensure that, yes, we can do it securely and efficiently, but that it is using data to help outcomes, that it's very much an outcomes focused rather than how many patients are we dealing with today. Because I think the fundamental learning that we've taken is from a patient perspective, and there's a lot of talk about, certainly in an election year, about productivity, but it can't be about the number of people that you touch in your service. It has to be about how you ensure that those people actually achieve things together with you. So that is very much a different shift in focus. So currently the data protection interpretation is holding that back.
Yeah, I think we've lost quite a bit of years kind of emphasising the privacy element of the GDPR when purposeful use was really the motivation for general data protection. And as you say, the patience is expiring on that, and it is about purposeful use, which is supported very strongly and almost demanded now by patients. I have a question on interoperability, but I want to go to the floor here. We have a question, and if you could introduce yourself, and we have others behind you.
Yes, Colin Walsh, Professor of Biostatistics at Trinity, and it's coming to Derek's point there. Specifically, I suppose I want to ask Dermot and Margot. Dermot, I think the Data Institute was part of your map. Is that the secondary use
Yes.
Is that clear with that? And Margot, what have you learned about secondary use?
So did the audience hear that question? So the question is about the Data Institute for Dermot and the use of that, but also Margot from the...
From the Netherlands, what has Margot learned about secondary use?
about secondary use of data.
What can we learn here?
To you, Dermot, first.
Yeah, the Data Institute exists because while a lot of information will be on the EPIC platform from social care, community care, the GP records will not be on the platform. And the Data Institute is to make sure we've got a comprehensive collection of information because 90% of care is delivered by GPs and they're not as yet on the platform. They do get a web browser access called Epic Care Link and they can order some tests on it, but they don't have a right capability and they don't record their own records. So the Data Institute sits separately for that purpose.
Super. Margot?
Yeah, we have a separate data warehouse in our hospital, but we can only do research on our own data. But I have two examples. For all ICUs in the Netherlands, now it is possible to be part of ICU data, and then you share your hospital data with the national database. And it takes a lot of time to make sure that that is happening. We are busy with it for years now, and it also takes time to plug in new hospitals. But then we are ending up with having a national database with all ICU patients, and then you can do research. Because when you do it in your own hospitals, with 80 hospitals, with 80 million people, then you don't have a large enough database. And that's the reason a lot of research studies are not reaching significant outcomes, especially for ICU. And the second is, when you are ending up with separate databases and you don't have data availability, you will never will be able to have good AI algorithms because you need a lot of data to get a good algorithm. So that's really a very important thing to have data availability. And you can have your own database, but it has to be available so you can access the data and do research on it.
Super. Go to the floor here. Thank you.
Hi, my name is John Gilmore. I'm an assistant professor here in the School of Nursing, Midwifery and Health Systems. My pronouns are here or there. One of the things thank you all for your great insights, and I've learned a lot. One of the things I'm a little bit disappointed with is that nobody has mentioned the potential for digitalization around reducing health inequalities, and for me that's really, really important. That's the area I work in, and I think what's important there is the data availability. And for my own areas, if we don't collect sexual orientation, gender identity data, or housing status data, we're never going to know about the health inequities that communities or individuals face. So I'm just wondering, is there any plan or potential or any reason why, maybe from the Irish contingent, why that hasn't been kind of incorporated or thought about, or is there potential for continued development of the type of data we're collecting in our AHRs?
Might pass down over to Damien, maybe. Would you take that?
Yeah, I mean, Colin mentioned at the start the challenge in the pandemic and trying to identify at-risk groups, whatever those groups were, Roman, traveller, homeless, and so on. So, and you mentioned others in terms of gender and other areas. So I think as part of the data side, because the HR will hopefully try and capture all of that, and the scope of that will determine exactly what we need to collect. But we also need to look at how then can we use that information to inform the planning of services, like you said, to make sure there's equitable access. The other area where I thought you were going is many of those groups as well digitally are detached and don't have easy access. Not all of them, but many of them are. So how do we make sure that someone isn't disadvantaged by being in those groups? Because there's often an alignment there, either socioeconomic or those groups themselves. So I think we're at a stage where on the data side, we can try and plan that in to make sure that as we pull our information together, we do have a central repository at the moment, but it's used more for operational purposes and it's weak on clinical data because we don't have the HRs to underpin it. And we need to work out, do we need to pull that in? Or in some countries, they've sort of can dip down and pull the information up to give you the sort of information that's talked about earlier. And I think the registries then are important, whether they're disease or for wider development, having some sort of national strategy about how those would develop. And certainly one of the things we intend to do is to talk to the HRB so we understand as part of that, as well as the chief academic officers, how can we build that sort of picture around it. It's easy to draw it on a PowerPoint slide, but it's harder to give life to it. But we are at a stage, as I say, because we're probably at a relatively low base where we can hopefully build that up. So certainly we would want to include the type of areas you're talking about so that you can look at those disadvantaged groups, whatever the nature of those people are, and hence the sort of solutions you design, whether the research you're doing or service delivery, operationally, which is what we look at in the health system, we can look and see, well, how are we making sure that we capture those groups, and also cognizant many of them are digitally detached as well in relation to access and so on.
Thanks. Great point. Another question here.
Hello. So my name is John Laffey. I'm an anesthesiologist, intensivist, and I'm Director of Research Governance at University of Galway and what used to be the SAIL of the hospital system. And so I wanted to just make two comments, then maybe a slightly pointed question. But so first is, I know from from the work in the Netherlands just how far ahead the Netherlands are compared to us in terms of their digital warehousing. They're getting their systems to talk to each other, particularly in the area of critical care. I would say they're at least 5 and probably closer to 10 years ahead of us there. And the second thing I would say is that, I totally endorse what Derek says about the real difficulties we've had with data transfer and GDPR. And some of that came from how we transposed the directive into legislation here. And so with those two things, I would be concerned at the feasibility of a 5-year time frame for a digital transformation. And unless we approach it in a radically different way to how we've done GDPR, we will get really mired, and it's really going to be very difficult. So I think it's really important that we learn from our prior lessons. And my question in a way is to Damien, and what confidence do you have that we will get this done in anything like 5 years?
Yeah, it's a good question in terms of timing. I guess, look, there's a couple of things. We need to set it up for success and put a pace there that we haven't before. That's the first thing. And while trying to factor in some of the questions here for the future, don't let, I suppose, try and put a pace into that we don't try and design everything perfectly now, because it's all evolving as well. But if we get the basic building blocks together, I would still be very optimistic over the next 5 years, subject to funding, but I know Murray will be working hard to deliver that for us in the department, but subject to funding, that we can actually then start to put pace and to move these programmes on. Northern Ireland, to be fair, if you look at the timings that Dermot talked about for an EHR, it does take time. Most countries, we spoke to Alberta, they're 5 million people, 4.9 million, 4 regions. They went through a 7-year cycle. So some of the things may go beyond that, but I think we have to be ambitious to try and get momentum. And I think if you can get momentum, people will generally in the health system come in behind you. If they see it's serious, if they see there's a commitment to it, my experience certainly over the years in all sorts of walks of life in it, is that people will come in behind it. So I think we do need to get the base building blocks right, though, because if we start out and we get some of those wrong, like you're describing, then I think we're challenged. And hence the reason we're talking to lots of other countries, Alberta, New South Wales. We're going up to the north to meet the team up there. And we've been talking to lots of trusts in the UK and so on as well, and understand how countries or even regions in bigger countries similar to ourselves have constructed it. And like I said, because we have a low enough foundation in some aspects, are there areas we can leap forward in? So we have a tender on the shared care record, the patient app will go live, it'll be phased. So there are things we're trying to use to build confidence, not just within the system, but also with government. Like, we have a history in Ireland around digital projects generally, not just in health. These are big projects, they're complex. Politicians, what's in it for a political system around it? We know how important it is. So we have to give them confidence as well, that patients feel there's a value in it, staff feel there's a value, and then hopefully the snowball can gather. So I would be very optimistic from where we're at, to be blunt. Will we get everything in that 5 or 6 years? Probably not. But if we got 80, 90% of the way to where we want to be, that'd be a much better place. And then you have another cycle. And it's changing anyway. Technology is moving at such a pace. Some of the things you think you might do a certain way now will probably change in 4 or 5 years' time. So I know from a research perspective, it's probably important to get some of the building blocks right, even as some of the data we're talking about might take longer to be able to populate in the way that we need. So that's why I think having a coming together, if you like, from a research, the chief academic officers coming on to the overall governance is really important, to try and see, can we design something around that? And that data role for me is one of the most important roles we'll appoint, which is trying to build out what that infrastructure would look like. Not solve all the problems of the data, but make sure we know as we do that, we can actually knit it together in a way that will give us what we want, and we've talked about here today.
Thanks a million, Damon. Good question. And I think you're right. The digitisation will take many, many years, but the opportunity to deliver real value for citizens early is the organisation of data in the meantime around citizens. A question here. Thanks.
Yeah, my name is Nia Clendenham, I'm a GP, and thankfully I haven't worked with paper records in 30 years. So I think we've all been working with electronic records for a long time. I think there is a missed opportunity in terms of your data collection from the community. But I'm also wondering, I see a lot of hospital projects there, and I'm just wondering, particularly in the context of moving care into the community, how are the community, I suppose primary care, but also general practice, how are they going to fit into your projects? I mean, I think Dermot answered the question, or mentioned your experience with the North, about how the platforms in general practice in the North interact with your own. I'm just wondering how practically, or what's the plan around that? Thank you.
Yeah.
So maybe over to Dermot on that one.
Yeah, and specifically for the community care, the community care, they were unable to turn down activity when they went live, but they actually managed the system incredibly well. It changed what they did. We had greater oversight and better governance. For giving an example, community nursing was, the governance around that was a retrospective review of 40 charts. And we moved immediately with governance over every instance of care at all places. And I think they embraced it incredibly well. Areas that embraced it very well were obviously ED, places that are used to working in a stressed environment and being very reactive. We integrate with the GPs, and the GPs can order on the system, but the GPs are not on the Epic platform. Am I answering your question correctly? And we're very conscious that the vast majority of healthcare and interactions in Northern Ireland are with GPs. And in fact, I heard a scary statistic that 1 in 8 patients see their GP at least once a week. That is not a sustainable way of working. So while we're busy changing and transforming within secondary care and community care, I think certainly my GP colleagues do feel a bit cold-shouldered, and I think they have to be honest about that. And I think our next phase, we will have to see what the solutions will have to be for general practice, because there's no point having a completely joined-up system except those that deliver most of the care.
Yeah, just very briefly, one is, look, I mean, none of us go into our GP. They're working on systems for years. They're the most technology advanced group that we have in the country, and we need to learn from that. That's the first thing I'd say. Secondly, implicit in most of those programs is general practice. So if you look at the laboratory, the first site that went live, GP ordering in North Dublin is all done electronically from the GP perspective, benefit to the GP, benefit to the hospital. So it's embedded in a lot of those programs, just to say that as well. And the third piece, I'd say then, in terms of the summary care record or shared care record, which is one of the key deliverables out for tender at the moment, product selected by the end of this year, plan to go live end of next year, early the following year. We've already been in discussions with the ICGP and the IMO about how do we collect that data, where are you going to get your prescriptions, your conditions, your allergies. Your GP knows that best, far better than any hospital. So we're in discussions around it. The data issue is one that's going to come up again. While there's one company in Ireland, as you probably know, for most GP systems, 3 products, the same product in many places, the data isn't recorded in exactly the same way. So there's a job there to how do we get to a stage where, Damien's meds are all of his accurate meds today. So just to give you that reassurance, GPs are embedded in that, and we're also actually, just talking earlier, getting all of the professional bodies involved in a sort of a group around how we support and drive this out. The ICGP and IMO would be part of that discussion as well.
Right, we maybe last 2 or 3 questions. We've got 2 here, and I've got 1 over here, so let's go for it.
Hi, my name is Dr. Marie Casey. I'm a consultant in public health medicine. I was clinical lead for procuring an IT system for public health last year for health protection. And I suppose this is probably directed towards Damien more than anyone else in the group. I found going through the DSMP process very useful around standards and data, and I think that's really a really important part. It's actually not mandatory, though, when you're procuring a system. That's actually really good practice, but it's not, and I suppose that's something I think is useful to think about. The second thing is around equity stratifiers. I'm picking up on the previous comment about inequalities. We don't actually have a consensus statement in the HSE on the equity stratifiers we should be collecting, and I think that's a really key piece of work in the next while as well.
I'm just sorry Colin Henry isn't up here now because he looks after public health, but I guess, look, all I would say is the first point, it's something we need to learn for all of our procurements in terms of that standards. And the second, public health, as it looks sort of at that helicopter view, the point that was made earlier, if we don't collect that information around people or we're not able to identify people, And that has been a tension in the past about that classification of me, for want of a better word. But I think if we're serious about recognising there are groups there, we need to be able to come back and address it. We had 2 really interesting presentations recently at a joint group we've set up between the CEOs in Northern Ireland and our CEOs in the regions here. And the difference in disparity between where you live in length of living in Northern Ireland in the big city areas, in our case sometimes rural areas, elderly people and so on, was phenomenal. So I think there are certain things we can do, but I hear what you're saying, and we need to make sure that we're clear how do we collect that. I don't think that's a digital issue. That's about addressing and being clear from both a population perspective and a service perspective, and that obviously benefits health planning and research as well. But take your point on board in both of those, yeah.
Last 2.
Austin Stack here, Chair of Medicine at the University of Limerick. Fabulous session and great speakers. I've been working on secondary data analysis for 20 years. And in the United States, most of the time, to get access to data takes about a few months. And then you do the analysis. In the Irish healthcare system, it takes about 1.5 years to get it and 6 months to do the analysis. So the challenge has been access to the information, and then we're typically knocking on the wall to try and do that. 2030, I think, is going to look very bright with the digital healthcare record. But I'm wondering at the moment, given that there are some really strong national data sets within the HSC, what can be done between now and 2030 to help fast track all the researchers here who want to conduct secondary data analysis to enable that, like the passion is out there, but it's getting access. So we need to kind of have a more streamlined roadmap. So I'm delighted that Damien has mentioned many of the positive things that we're doing. So Damien, because I know you're heading up the technology and transformation section, what do you think we might do to try and accelerate that in the next few years?
Yeah, I don't have the answer here, Austin. What I would say, it came up yesterday, actually, interestingly, a few of us were in a conversation with the Swedes in relation to, and it came up from industry on our side again, the challenge they get, that it takes so long to get it through, like you said, years to get, and then X months to, or whatever, to do your study. It probably is something from today with the chief academic officers to bring back into, I'm not an expert in relation to that area, but I think it is about probably pooling people, the department from the policy side, ourselves, the academia, and saying, look, how do we do this better? Because as you say, we have good cancer registries, we have other registries where we have good data, but yet there seems to be this challenge in getting access to it within where we are today. And I suppose a lot of the things we're going to drive are about improving the pool of data that we'll make available. It sounds like there's a fundamental issue that you've outlined, which is how do we accelerate that access while still giving the protections and things that are there. So we probably do need to put a focused piece of work into it. And I'm saying that as someone who isn't expert in that area, but it does strike me just from the feedback that it's something we need to look at.
What might be useful
ask
if
Derek.
you appointed somebody within to kind of support that? You know what I mean? Somebody within the division to support that might be very helpful. And
probably, sorry, I know Tim wants to let others in, is there is a head of research in the HSE. We obviously have this chief data person coming in, and we have other people. So it is probably with the department and others maybe trying to look at how do we unlock some of those things while we build that up. And I'm not an expert in it, so I won't pretend to say, look, this is the answer. But I think that it is about getting heads together like all these things to see how do you break it out.
Derek, did you want to comment?
Yes, and I'd be familiar with Austin's work in terms of the end-stage renal work that he's been doing. And I certainly, what we found, and one of the key building blocks would be to build a trusted research space or a secure processing environment. So that's where you can actually, whether it's at a hospital level or whether it's at a national level, you can at least create that trusted space so that if and when the public do challenge, and the public will challenge things, that at least you have created an infrastructure so that the data can actually be flowing into, even in a protected environment. So, we were involved in an initiative called Dandelion, which was to try and create that in Ireland. And I certainly, when we look at the North in terms of what it's been able to achieve in that respect, plus the plans to bring in a public advisory panel to ensure that the data sets do actually get released in line with the duty to share, so that you actually have the public with you on that journey towards realizing that there will be challenges along the way of releasing data, but create the infrastructure in the first place.
Last question.
Conor Green, I'm a professor here in the UCD Centre for Children's Orthopaedic Research. And just to follow on it from a comment that Niamh made about primary care. So we're about to spend a lot of money on a system that works for about 5 to 10% of healthcare. And Damien, as you'd say, yes, you're setting up solutions to work with GPs, but remember, they bought all their own systems themselves and didn't get any support. And if Margot and Dermot, if you could go back now, and Derek, would you feel you get more engagement actually if we rolled it out to general practice first? And if you could go back again, would you go to the community first?
Part of our driver for an electronic care record was the 70 systems within hospitals, and the PAS systems were near senescence. So that probably wasn't an option. But I think the decision to say we'll look at the GPs at some non-specified time in the future was a big mistake, because general practice is rapidly changing. That slide I put up with the number of GP practices out of date, because it's certainly in rural areas it's difficult to recruit, and the numbers are decreasing. So while we're trying to invest a lot of finance into new ways of working within secondary care, the vast majority of care is delivered in primary care, and I think we need to rapidly turn around and think about how we provide that transformation for general practice, because general practice, certainly in Northern Ireland, is not really sustainable in the model and the way it is. And although that they have systems which are partly manage their business as well as deliver patient care, and they've been digitalised for many years and ahead of hospitals, I think they do need the resource and funding to move them to the next level.
It's very difficult to start it, because we have a region around our hospital with GPs, and who is going to have the talk? Because we also have a lot of systems for the GPs. We as a hospital are not the ones who are able to make the change. We tried to talk with the GPs. Why aren't you going to Epic? Because then we have the same system and Epic is ready for primary care. But for them, what's in it for them? It costs a lot of money, and at that time there was no incentive to do so. So when you want to do that, then you have to do it from the government. And they don't say you have to have the same system for the GPs, because, well, we don't have it in the hospitals as well. So we are making the change and a lot of infrastructure. So where you are now, you have the possibility to make the nationwide vision, because you have to do it nationwide. That's what I would do different if I could do it over.
Okay, thank you. I'm going to call this session to a close. Thank you for all the questions.